Continuing our discussion of the central nervous system, in the previous lecture, we discussed about the motor system and the various motor weakness and the motor abnormalities. In this part of our discussion of the central nervous system, we are going to discuss the sensory system. We are going to discuss the basic anatomy of the sensory nervous system, how is it planned out over the course of the body, and then we are going to discuss a few types of sensory laws and what are the various abnormalities and the various presentations catering to the different area of the central nervous system. The sensory system is more or less in the subconscious mind. You perform all the activities of the daily routine, all the senses, the sense of sight, sense of smell, sense of touch, you perform everything subconsciously. So in the normalcy or in a normal environment, whenever there is a perfect functioning of the sensory system, you don't even appreciate consciously what you are doing. But whenever there is some sensory abnormality and it manifests as some sensory loss, for example, in the form of pain or hyperthermia, then we focus on the sensory abnormalities and it becomes conscious to us. So the basic anatomy of the sensory system, as we all know, it starts all the way up from the sensory receptors located at the level of the skin or the joints and the muscles. Then by the help of the sensory nerves or the peripheral nerves, they move towards the sensory ganglion, and from there onwards it moves into the spinal cord, and with the help of various tracts the sensations are carried out all the way up to the cerebrum. And primarily the sensory cortex is located in the postcentral gyrus and spans over the area of the parietal cortex, and this is the part of the brain that helps us appreciate the various types of sensations. We're going to discuss a few types of sensory loss. Now, the abnormal sensory systems, in broad terms, are classified into two major groups. We classify them as either positive or either negative sensory systems. With the term positive means that in addition to the normal sensations, there is some addition or the hyperfunctioning of those normal sensations. And what is the reason for these positive abnormal sensory systems? The major pathophysiology is that there are train of impulses which are generated at the sites of lower threshold. So either be it pain, touch, temperature, or any other sensation, the threshold for appreciation of these sensation has been lowered, and that leads to the positivity or increased presentation of these sensations. Similarly, there is also heightened excitability along a peripheral or a central nervous system pathway. We are going to discuss what are the various positive symptoms in the next coming slides. On the other hand, we classify the symptoms as negative symptoms if, for example, there is an absence of a normal sensory stimulus or a sensory system. For example, if there is absence of the touch or absence of a normal sensory response, then we classify as that something is missing, and that's why we broadly classify it as a negative abnormal sensory system. And the main pathophysiology behind the negative system is there is loss of the afferent axons or the loss of the function or the anatomy of the afferent axons. Now let us discuss in slight detail what are the various positive and what are the various negative symptoms. The positive symptoms are generally the tingling sensation or the pain prick sensation, the itch or the pricking sensation. These are the additional symptoms which are not present in everyday routine or are not part of the normal sensations. Similarly, if there is some lancination or aching or dull pain, that is also classified as an additional or a positive symptom. In all these positive symptoms, one thing is common, that there is some type of pain, either a dull or aching pain or a tingling or a pinprick sensation. There is some additional sensations which we feel apart from the normal touch or temperature sensation. Similarly, these sensations can also feel like knife-like or twisting feeling. The patient might present to you saying that he has some abnormal sensations on his arm and it feels like someone is stabbing a knife in his arm. So these kind of normal symptoms are being reported by the patient if there is some abnormality of the sensory system. Similarly, the patient might draw his arm or leg away from that stimulus. There might be some pulling or tightening of the area involved in abnormal sensory association. Similarly, there might be some certain burning feeling in that part if there is alteration of the thermal receptors or the thermal sensation and along the pathway of the sensory system. So all of these kind of symptoms are generally classified into positive symptom. The patient might also complain that he is feeling that some electrical feeling, like a current or electricity moving along that path. For example, in various abnormalities like trigeminal neuralgia, where there is abnormality of the fifth nerve, the patient reports to you with classical presentation of the symptom, and the patient describes the symptom as some electrical feeling going around the part of the face which is supplied by the trigeminal nerve. So these symptoms, which are tingling, itch, lancinations, or knife-like, the burning sensation, or the electrical sensation, these are additional or hyper symptoms to a normal feeling of touch or temperature. That's why we classify or term them as positive symptoms. On the other spectrum, we define the symptoms as negative symptoms if there is absence of the normal sensation of touch or temperature. For example, if there are diminished or absent feeling or cutaneous sensation, you touch something and you don't feel it just like a normal sensation, there is diminished or absent cutaneous sensations associated with a sense of touch, or there is numbness at certain area. The patient might come to you and report that he feels that his arm is numb, and when he touches, he doesn't feel like a normal sensation, a normal sense of touch. Similarly, if there is a complete lack of cutaneous feeling, that's why in all these symptoms, one thing is common, that the presentation of the disease or the presentation of the system is reduced in intensity as compared to a normal sensation. That's why we classify them in a bracket of negative symptoms. Now let's go over certain terminologies which are involved when we describe the sensory system. We use the term paresthesias for pinprick sensations like needle or pins-like sensations. The patient might come to you and say that I feel like someone is poking the needles or the pins in my hand. The medical terminology we use for that is paresthesias. Dysesthesia is another expression which describes an altered feeling of sensation. The difference between paresthesias and dysesthesias is that in paresthesias we include the different feeling, the different sensations apart from the pain stimulus. When we involve the pain stimulus and everything else which is included in paresthesias, we term it as dysesthesias. So dysesthesias also involve the pinprick sensations, along with that the sensation of pain which is described by the patient. Hypesthesia or hypoesthesia is a diminished cutaneous sensation, reduced sensations of touch, or reduced cutaneous feeling of any stimulus. Hyperesthesia is exaggerated. Hyper means more, exaggerated response to a stimulus. For example, if you touch some benign object which is not harmful for you and you feel exaggerated cutaneous response, that is termed under the umbrella of hyperesthesia. Allodynia is a term which we use for any abnormality in which a stimulus which is under normal conditions not harmful for the patient, but it is perceived as harmful or it is perceived as painful. For example, if you touch a keyboard or a pen, but you don't feel the sense of pain in a normal person. But in allodynia, if a person touches a keyboard or any other object which is not painful in normal terms, but the patient on touching that object starts feeling the pain and abnormal pain, then that pathology is termed allodynia, the presence of a pain stimulus in the absence of any noxious stimuli. On the other hand, hyperalgesia is exaggerated response to a very minor noxious stimuli. Here, someone, for example, if you just touch a pin and it is not very painful in a normal person, but hyperalgesia is someone who is very responsive to pain, and he might feel an electrical or a shooting pain in that pain, and that pain might be unbearable for that person. So an exaggerated response to the sense of pain is generally termed as hyperalgesia. It is important to differentiate allodynia from hyperalgesia, because in allodynia there is no noxious stimuli and the patient starts feeling pain upon just feeling the normal stimuli. But in hyperalgesia, we have certain noxious stimuli, but there is an exaggerated response to that as compared to a normal person. Similarly, hyperpathia is another term which generally involves all the things which are involved in hyperalgesia. So hyperalgesia and hyperpathia can also be used intermittently or exchangeably in certain literature. These are certain terms which are important to get familiar with when we talk about the sensory system. Now let's just quickly revise the anatomy of the sensory system. Here is a diagram which is representing all the pathways. Let us first label this diagram, and then we are going to go through the different parts. Here is the thalamus. There is the internal capsule. We have the principal sensory nucleus of the fifth nerve or the trigeminal nerve. Then we have the nucleus of gracilis, a nucleus of nucleus cuneatus. The gracilis is the medial located nuclei, and the nucleus of fasciculus cuneatus is laterally located. We also have the nucleus of the spinal tract of nerve 5. This is at the level of the medulla, which we are going to label in just a second. Then this structure in the thalamus, where all the pathways are converging, is the ventral posterolateral nucleus of the thalamus, or the VPL nucleus of the thalamus. This is the relay station in the thalamus of all the sensations arriving in the various tracts, as we are going to see. The VPM, or the ventroposterior medial nucleus, is the one which is involved with other or the motor pathways generally, but the VPL is the one which is involved with the sensory stimulation. Here is the midbrain. This is the pons, in which medial lemniscus is shown. And here is the medulla with the labeling of the spinothalamic tract. We are going to go over all the tracts in just a second. Now, as we have labeled everything here, let's just go through it quickly. This is a normal brain, and this is the brainstem involving the midbrain, pons, and medulla. Here is the spinal cord. Now, this is the sensory nerve which is arising from a peripheral receptor. There are generally two types of peripheral sensory receptors. The one are the free nerve endings, which are involved, which are small nerve fibers, and which are basically involved with the sensations of pain and temperature. So these are the small free nerve endings which are present on your skin, in abundance, and these basically sense the sense of pain and the sense of temperature. The other sensations, which are the position sensation or the vibration or the 2-point discrimination, these are generally sensed by the large myelinated receptors or the mechanoreceptors, and these sensations travel in the large myelinated nerves. So all these nerves, they go through the periphery, they are collected from the peripheral nervous system. In the peripheral nerves, they move to in the spinal ganglion, and in this sensory ganglion, afterwards they enter the spinal cord. And there are two types of general sensations. The pain and temperature in the small nerves are relayed, and as they enter the spinal cord, they just move one or two units above, one or two levels above the spinal cord, and then they cross towards the other side of the spinal cord. And afterwards crossing, they start moving in the spinothalamic tract. This is termed as the anterolateral spinothalamic tract, and as you can see here from the spinal cord, it moves all the way up from the medulla to the pons, and then it moves into the relays in the ventral posterolateral nucleus. Here, after relaying, it moves to the somatosensory cortex, which is the postcentral gyrus, and involves the parietal lobe. So the first order neuron is present in the spinal ganglion, and then afterwards it crosses or transverses the spinal cord and moves all the way until it relays into the ventral posterolateral nucleus, and then and afterwards it is transferred to the postcentral gyrus or the somatosensory cortex. The other large myelinated nerves, which are carrying the position, joint, or vibration sensations, they enter the spinal cord in the dorsal column, and from this dorsal column they move ipsilaterally all the way up till medulla. In the medulla, these are relayed and form connections with the nucleus of the nucleus gracilis or the nucleus cuneatus. The sensations which are carried from the legs, generally they form synapse in the nucleus gracilis, and the sensations carrying from the arms or the lateral part of the body, they relay on the nucleus cuneatus. After relaying in the medulla, they start ascending and cross the medulla in this great medullary decussation. After crossing the medulla, they move to the contralateral side and start traveling in the medial lemniscus at the level of the pons. So this pathway is generally termed as the dorsal column medium lemniscus pathway, which carries the joint and the position or the vibration sense. The pathway which carries the pain and temperature sensations all the way up to the brain is termed as spinothalamic pathway. So continuing our discussion of the dorsal column medium lemniscus pathway, in the medial lemniscus, it is carried out, the sensations are carried out from to the pons and the midbrain, and it again relays into the ventral posterolateral nucleus of the thalamus. And after relaying here, they are spread out all the way up to the cortex. So this is the basic anatomy of the sensory system. The important thing here to remember is the demarcation. The spinothalamic tract quickly transverses to the other side just as it enters the spinal cord, while the dorsal column nuclei, they move ipsilaterally until the level of the medulla, and at the level of the medulla, just like the corticospinal tracts, they decussate to the contralateral side and then move in the medial lemniscus and then transverse all the way up to the cerebrum. Here is the representation of the various types of nerves which are involved, the sensory nerves in the body. This is an exhaustive list, and I don't want, it is very difficult to remember everything. Just have an idea of the various types of sensations which are carried out at the various levels. Like which nerves are supplying what is the sensory supply of the forearm? It is from the musculocutaneous nerve. The radial nerve supplies the posterior side. The axillary nerve supplies the upper part. The ulnar nerve supplies the medial part. And here on, depending on the various types of abnormalities, we can pinpoint the lesion and pinpoint the nerve which is problematic in this case if we are having numbness or pain. And then from the nerve, we can trace out the nerve pathway all the way up to the spinal cord and can have an idea of what is the major pathology involving someone. For example, if someone presents with numbness of the ulnar nerve here in the medial finger, then on the small finger, then you can trace it out all the way up to the spinal cord, and you can have a good idea that either the problem is at the level of the wrist or at the level of the medial side of the elbow. And this is important in or helpful in localization of the sensory problem. All right, now let's discuss how do we clinically examine the sensations. What are the various tests which we perform? These are generally performed at the bedside, which help us in localization of the problem or help us in evaluating which sense is abnormal in patients. So to check for the sensation of pain, we generally use a pinprick sensation. We use a small needle and just prick the patient and ask the patient, while the patient is not looking, where he feels the pain. Then we use this pinprick test to evaluate the various areas along the various dermatomes or the various nerves. And if we can compare them on both sides as well. And then based on our assessment, we can pinpoint where is the problem or where is the exaggerated response to pain in this patient. This might be hyperalgesia, this might be allodynia. Then on further evaluation, we can further define the extent of the problem. Similarly, the temperature or the heat is sensed with the help of some warm metal object. We ask the patient to touch a metal object after just slightly warming it. And then on the basis of that, we appreciate that on both sides, we compare the problem and we can touch the warm object to various parts of the body as well, where which helps us to evaluate the various dermatomes or the various sensory nerves. For the cold metal object, we can slightly use a metal object which is slightly cold, and this helps us in identifying whether the cold sensations are intact or the heat sensations are intact. Similarly, for touch sensations, we use a cotton wisp or a fine brush. Asking the patient to close his eyes, we just rub a cotton wisp on the patient's skin and then ask him to raise his finger on which part of the body we are touching the cotton wisp, or just tell us in where he is feeling the sensations and then comparing them to the both sides and moving it over the various parts of the area affected, we can demarcate the problem, that whether the problem is localized to a certain area of the body or a certain dermatome, or it involves multiple nerves or the multiple dermatomes. This helps us in identifying that whether the lesion is localized or it is a general problem. For example, the sensory system abnormalities might be because of a localized lesion, which is termed as mononeuropathies, or it might be a polyneuropathy, which is because of a generalized problem, like in diabetics who have a glove and stocking problem, in which there is generalized paresthesia, generalized distal extremity weakness, or in someone with a vitamin B12 abnormality, we also have certain polyneuropathy. So this type of examination on the bedside is very easy to do, and it gives us a good idea or indication of the extent of the problem. Similarly, to touch the vibration sensation, we use a tuning fork. We vibrate the tuning forks and then move it over the various joints or the various parts of the body, the various tendons, and then gives us an appreciation of the vibration sensation, and which in turn, the vibration sensation gives us a good idea of the integrity of the dorsal column median lemniscus pathway. So these are the basic investigations which we do at the bedside to test for the primary sensations. For the joint position sensation, we move the joint passively. We perform the passive movement of the joint. This gives us a good idea. We can use a tuning fork as well to check for the vibration of the joint position sensation. But with the help of the passive movement of the specific joints, it gives us a good idea of the tone of the muscles as well, whether there is a joint abnormality. The joint abnormalities can be because of a sensory problem, or it can be a rheumatological problem as well. And then that passive movement of the joint, or the examination of the joint, can help us in identifying the or differentiating the various abnormalities. All right. Now let's discuss a few quantitative sensory testing. These are the ones which give, the previous ones were the ones which are generally the qualitative tests, in which we appreciate whether there is abnormality or not, or normal functioning. But the quantitative sensory testing can give us a quantitative figure of the magnitude of the problem involved. So there is certain quantitative sensory testing in which the nerve conduction studies we do, or the EMGs we do. They give us an idea of the extent of the problem. These are not performed in every setting, or not available in every settings as well. So we start off with the qualitative testing, and if needed, then we switch off onto the quantitative sensory testing. Along with that, there are certain threshold testing for the touch, vibratory, and the thermal sensations, in which after reaching a certain threshold, we can classify the disease as the mild, moderate, or severe, and we have the various landmarks for, or the various cutoff values for that threshold. Now, how do we know that the problem which we are experiencing is at the level of the cortex and not at the level of the sensory nerves, or the level of the spinal cord? The cortical sensation, because the area somatosensory cortex involves the parietal lobe, so there are certain specialized tests which are developed for testing out the cortical sensations. These important tests are the number one is the 2-point discrimination, in which we use a device which has two needles simultaneously, or a calibrated device, and then we touch the various areas of the body, like you can see here, up to the difference of about 1 to 3 to 8 millimeters. We can start moving this device, or we can start extending this device to check the various areas involved. For example, here you can see that at just a distance of 1.1 millimeter, we are touching the 2-point discrimination, that whether the patient feels these two different pins touching the tongue or not. It is important to marker. The 2-point discrimination is an important marker and gives us a good idea of the integrity of the spinal of the cortex, and also of to some extent of the medial lemniscus pathway involved. Similarly, here at the level of the finger, we are touching this instrument at the level with the distance of 3 to 8 millimeters, and we can expand it all the way up till 36 to 75 millimeters by touching it over the back or the shoulder. And the various types of distances at which the 2-point discrimination is appreciated can be compared. And if if there is certain abnormality at one level, then based on the mapping of that area readily moving outwards, we can have a good idea of the level of the problem at the area of the brain which is affected in this part. So 2-point discrimination is one way to check for the cortical sensation. The other pathway is the bilateral simultaneous stimulation. Just like in the previous test, we bilaterally simultaneously stimulate the 2 points. They can either be at the same part of the same side of the body. For example, here on the dorsum of the hand, we initially touch the 2 points simultaneously, and then we can ask the patient whether he or she appreciates these bilateral points of the simultaneous stimulation, or we can move it outwards and then we can spread it on the both sides. It can either be on the same side, and the same sides are generally classified as either distant, near, or the complex near pathway, which are very close to each other, or we can classify them as either bilateral, and we can check them on both sides as well. So this bilateral simultaneous stimulation is another way to check for the cortical sensations, and this gives us an idea of functioning of the cortex in the both cerebral hemispheres. As you know that the sensations, they generally cross and move towards the contralateral cortex. So if we have problem, for example, in the left hand, and there is no abnormality in the right hand, then that we can trace out this left hand abnormality to the right side of the cerebral cortex, because the fibers, they generally cross in the spinal cord. Certain other examination tests are the touch localization. We touch the various parts of the body, and then we ask the patient whether and which part of the body the patient feels the touch, or we can do it in a bilateral manner as well to check or compare the both sides. Similarly, there is a test which is called graphesthesia, in which with the patient asking the patient to close his eyes, we draw certain figures in the hands of the patient, like the figure of 3 or A, B, C, and ask the patient whether what are we drawing, what is he feeling. If the patient answers correctly, then the patient can appreciate this movement. And if the patient answers abnormality, then this is a classical sign of the cortical problem, because the parietal cortex, which is involved with the sensory stimulation, is also involved in this appreciation of the movements or the appreciation of the texture of the various parts, like stereognosia or graphesthesia. So this parietal cortex, along with the sensory stimulation, also gives us a good indication of the various types of the shapes involved, or the various, especially the left side of the parietal cortex, or the various parts of the body, the position of the various parts of the body. So with the help of this graphesthesia, we can evaluate this parietal cortex very nicely. Similarly, there's a test which is called stereognosia, in which we ask the patient to close his eyes, and then we give the patient various objects to grab. The patient, for example, we might give a key to the patient and ask him to describe this object with the help of a sensation of touch without opening his eyes. So the patient might describe that this sensation might be this might be a key, or we can use a pen and ask the patient to describe what is the shape of this object, and with the help of just sense of touch without looking at the object, the patient describes this, and this test is named as stereognosia, which is helpful in the appreciation of the object with the sense of touch. And abnormality of this sensation is generally termed as astereognosis or astereognosia, and it is generally an abnormality of the parietal cortex, in which we have the somatosensory system. So these are the basic tests which are used to evaluate the sensory system at the level of the cerebral cortex. Now, what are the various key observations which we have to keep in mind while we are examining the sensory system and while we are trying to localize the sensory abnormality? The number one is the extent of the problem, whether it is a localized problem or it is a generalized problem, or it is involving the various areas. If it is involving just a very small area, then this might be a localized issue with a mononeuropathy. If it involves the whole hand or the whole arm or the whole one part of the body, then this is a generalized problem, and it can be at the spinal cord, or it can be at the level of the cerebral cortex as well. Similarly, the configuration of the problem, whether the problem is unilateral or bilateral, or it has multiple areas of sensory deficit located abruptly at different parts. This is very important to identify, to assess the sensory system. The symmetry, with either the bilateral symmetrical distribution or a unilateral symmetrical distribution. This also gives us a good idea of the area of the nervous system which we have to focus on. The quality of the problem, whether the intensity is very small or very large, or for example, the terms allodynia or dysesthesia, they are evaluated to describe this quality of the problem or the various types of the problem. For example, either it is a pricking sensation or a burning sensation, or someone like stabbing a knife sensation. These various terminologies which the patient describes give us a good idea of the evaluation of the problem and help us in identifying the issue. Similarly, the severity, the extent of the issue, give us a good idea of the localization of the sensory problems and also the extent of the problem. These are the important things which we keep in mind during our history taking to evaluate the sensory system, and these give us good clinical clues to localize or the lesion at the level of the spinal cord, or either a brain, or at the level of the sensory receptors. Now, if there is a nerve and root problem, then what are the various types of presentations which we can have? A root lesion generally presents with a deep or an aching pain. For example, if someone is having a problem with the L5 or S1 intervertebra, or the nerve root which is originating from the L5 or the S1 area of the spinal cord, the problem with that nerve root lesion is generally termed as sciatica, and that generally presents, the patient will present with a deep or an aching pain localized all the way in the track of the L5 or the S1 nerve, generally in the posterior part of the leg, all the way up till the knee joint or the thigh. If we have isolated mononeuropathies, then they generally present localized to one area of the part, but the symptoms can extend beyond the territory because of the overlap of the various other nerves which are involved in those areas. When there is just one nerve abnormality, the other nerves trying supplying those areas try to compensate for this problem, and then that's why the symptoms might extend beyond the territory. But generally, they are located along the single nerve pathway. If we have multiple mononeuropathies, then the symptoms and signs they occur in the discrete territory supplied. For example, if we have the problem at the level of the elbow, then all the way down, all the symptoms downwards in the elbow, which involves the radial and the median and the ulnar nerve, they will be affected, and the signs and symptoms will occur in the discrete territories. The ulnar nerve territory will be at the medial 1.5 fingers. The median nerve will be the lateral 3.5 fingers, and the radial nerve will be at the posterior side. Similarly, we have polyneuropathies in which there are multiple areas of the body which are affected. Now, this polyneuropathy is generally graded, and they are generally distal and symmetric in distribution. The important thing here to remember is contrasting to the mononeuropathies, which generally involve an anatomical problem at the level of that of the area involved. The polyneuropathies can be an anatomical problem, or it can be a systemic problem. For example, in someone with diabetes, uncontrolled diabetes, or a long-term diabetes illness, they can present with a distal and asymmetric, which we could term as a glove and stocking problem, in which there are altered sensations at the level of the wrist and at the level of the elbows, and the patient has less cutaneous feelings or altered sensations in these parts. These patients might burn their hands because of their inability to appreciate the sense of warmth or the temperature. And similarly, with vitamin B12 deficiencies, they can present with a distal and the symmetric problem. So, for when we have a patient with a polyneuropathy, we have to evaluate the sensory system and also keep in mind that this might be a generalized problem, especially if we are unable to find a localized problem on our imaging and other investigations. Now, let us look at certain other nerve and root abnormalities. If you have a lesion of the upper cervical cord or the brainstem, then that generally involves the both hands and feet. And this can be a lesion of the spinal canal, for example, someone with syringomyelia, or in other types of various abnormalities. There is an upper level of the sensory disturbance which helps us in localizing them to the dermatome or the part of the spinal nerve which is involved. If we have the small fiber neuropathies, the small fibers are the ones which generally carry the pain and temperature sensations that I told you in the start of the lecture. So there will be an abnormality of the pain or temperature sensation. This might present as a burning or a painful dysesthesias, or it might present in a form of a reduced pinprick and thermal sensation when we evaluate that with the help of a needle and a warm or a cold object. The proprioception, motor functions, and the DTRs or the deep tendon reflexes, they will be spared because the proprioception and the joint sensations, these are majorly carried out in the dorsal column median lemniscus pathway, and these are carried out by the large nerves, not the smaller nerves. So there will be sparing of these pathways, and there is the alteration of the pain, prick, and the temperature sensations. And this differentiation or dissociation of the sensory pathway is termed as sensory dissociation, in which certain sensations are intact and certain sensations are lost or abnormal. Similarly, if we have large fiber polyneuropathies, which are generally carried out in the dorsal column median lemniscus pathway, then there will be an alteration in the vibration and the position sense deficits. There will be sparing of the pain and prick sensation. When we have a vibration in the position sense deficit, then this can also present as an imbalance. The patient might present with a fall, or someone who says that I am not able to turn properly, I don't appreciate where my feet are relative to the ground. The patient might also present with the absent deep tendon reflexes. There might be a variable motor dysfunction as well in the large fiber polyneuropathies, because the corticospinal tracts, they also are large fibers. So a variable type of motor dysfunction can also accompany a vibration and a position sense deficit. This is generally termed as dysesthesias, and because the alteration of the sensory system. Dysesthesia is a term which we use for the alteration of the sensory systems. If there is a sensory neuronopathy, it can present as pain and numbness, either localized to certain part, or it can be generalized if it is at the higher level. There might be sensory ataxia, in which patient has difficulty in moving and maintaining his balance, or where we can have impairment of all the sensory modalities, which we generally use as the pan-sensory modality. So these are the general types of abnormalities whenever a nerve or a root is involved. In these two flow charts, the previous slide and this slide, we have basically given you an overview of what can be the various presentations and how we are going to trace it to the level of the spinal cord or at the level of the cerebrum. Now let's look at how we are going to localize the problem to the spinal cord. These are the various types of dermatomes. Now understanding these dermatomes is important because based on the area affected, we are going to localize it to the problem. For example, let's talk about the L4 and the L5 problem. The L4 and the L5 dermatomes are present in the anterior part of the leg and the medial part of the leg. So anyone who presents with an L5 or an S1 problem, he will have problem on the lateral part of the leg or the dorsum of the foot and the side of the foot, because the L5 and the S5 is a classical distribution of this presentation. And we can, on examination, we can trace it down all the way up to the spinal cord. Similarly, with an ulnar nerve injury, we can differentiate whether it is at the level of C8 or T1 or T2, because there are various levels which are mapped out on the skin. It is important to understand that these levels don't generally coordinate with the area of the spinal cord. For example, the L5, which is present at the lumbar area, generally is the skin dermatome which is associated with that is generally very low down at the level of the foot or at the level of the leg. But L5 is located in the lumbar area. So their relative position on the skin doesn't give us a good, a perfect association of their relative position on the spinal cord. And it is important to understand and memorize this to evaluate the sensory nervous system during a clinical examination. Let's talk about the brainstem. If the lesion is in the brainstem, it might be in the lateral medulla, and this part of the brainstem is where the pathways haven't yet crossed. So there will be a cross pattern of sensory disturbance. The pain and temperature have crossed in the spinal cord, and the dorsal column and the medial lemniscus, they are traveling ipsilaterally. So we will have pain and temperature loss on the contralateral side and a loss of the position or the vibration touch at the on the ipsilateral side, and that's why it is called a cross pattern of sensory disturbance. Now at the level of the medulla, the fibers then cross, the dorsal column crosses to the other side, and all the sensations are carried out in a contralateral fashion. So if higher above in the brainstem at the level of the pons and midbrain we have an issue, then this will involve the pansensory or the loss of all the sensations contralaterally. This will involve the spinal thalamic tract, and this will also involve the dorsal column medium lemniscus pathway. So all the sensations, the pain, temperature, vibration, 2-point discrimination, they will all be lost on the contralateral side. So this examination is very helpful to us in evaluating or mapping out the problem to the level of the brainstem or the level of the brain. Similarly, if there is an issue in the thalamus, for example, in the ventral posterolateral nucleus of the thalamus, where all these fibers relay, we will have a hemisensory disturbance on one side of the body, generally on the cross contralateral side, with the tingling and the numbness sensation all the way extending from the head to the foot, because VPL is the area in which all the sensory sensations except the face, they are carried out. The VPM, the ventral posterior medial nucleus, is the one which carries out the face sensations. So examining the face, examining the head and foot differentiately, and then differentiating the problems and these two sides, and also on the right or the left, we can localize the problem very nicely to whether there is a VPL nucleus problem or a VPM nucleus problem, and whether it is on the right side of the cerebrum or on the left side of the cerebrum. Similarly, if generally these problems are on a very small scale and they eventually present over a period of time, but if it is abrupt in onset, then that generally tells us that this might be a small stroke, like a lacunar infarct, in which there are certain vessels which bleed in a patient with hypertension, or might be an aneurysm rupture of the artery supplying the thalamus. This can present acutely, and the onset of this problem can be very abrupt. Similarly, there is a syndrome which is termed as the Dejerin-Rossi syndrome, in which there is hyperalgesia or the hyper appreciation of the thalamic pain. We also term it as a thalamic pain syndrome, in which patient can feel, or the patient can dramatically tell you that I feel this electrical sensation going all the way up my legs and arms, and I can't sit properly, and there's a very high degree of pain, or the patient's threshold for pain is very much lowered, and this is a very painful stimuli for the patient. Patient is very much at end rest. If it involves the whole side of the body or the hemisensory, then we generally term this as a Dejerine-Rossi or a thalamic pain syndrome. Then we treat this with the help of various medications. Similarly, at the level of the cortex, what can be the symptoms along with the various sensations? There is contralateral hemi-neglect, in which the patient just neglects one side of the body. This is very common, especially if there is a right parietal lobe lesion, then the patient might just forget about the left side of the body. And for example, if you ask that patient to draw a face of a person, then the patient might only draw the left side of the face, or the patient might only dress on the right side of the face, or in females, they might only do makeup of only one side. Just completely neglecting the other side, and that localizes the problem to the contralateral cortex. For example, if the patient is neglecting the left side, then there is a lesion in the right side of the parietal lobe. Similarly, a much smaller extent of this problem is the hemi-attention, which the patient doesn't neglect that side, but just there is less attention on one side and more attention on the other side. Similarly, the patient might just use his one arm. There is a tendency not to use the affected hand and arm. If you, for example, in someone who is generally a left-handed person and he normally uses his left hand to write and everything, you ask that patient to lift an object or write something, he starts writing with the right hand. And he forgets about it that he's a left-handed person and he has been using this for his lifetime. So these are generally located to the right side of the cortex, because that is involved in the appreciation or the three-dimensional localization or presence of the body as compared to the three dimensions. The primary sensations are generally intact on clinical examination. Because the nerve roots are intact, the spinal cord is intact, the primary sensations of the primary examinations are generally intact. But there is a generalized problem of neglect or hemi-attention. And there is a term which is the pseudothalamic syndrome, which is in which the problems or the symptoms are the ones which give us an idea that they might be arising from the thalamus, but they are actually arising from the cortex. That's why we use the term the pseudothalamic syndrome. Or there might be a contralateral loss of the primary sensation from the head to toe, which we also term as dysesthesias. So these are the various types of presentations of the cortical problems that present to us. These are the various systems which we can localize them. Now, the sensory abnormality can also present in the form of seizures, which we termed as the focal sensory seizures. These can start out as focal lesions involving a small part of the brain, and they can later on generalize as well. Let's look at the various clinical clues in addition to the seizures that we have, in terms of which we can describe it as a problem involving the sensory cortex. The areas in the brain are the lesions in the postcentral or the precentral gyrus, generally in the parietal cortex, which the somatosensory cortex. The principal symptoms along with the seizures is the tingling sensation. The patient will describe that he feels certain tingling sensation in an arm, and then the arm might start having a focal seizure. Along with that, there can be certain additional symptoms like the patient might have a feeling of rushing or hyperactivity, or there is a sense of warmth or altered temperature sensations. There might be a sense of movement without the detectable motion. The patient arm might be at rest, but the patient will be saying that I'm feeling that my arm is basically moving. So these all symptoms or clinical clues give us an indication that the lesion might be higher up in the cortex. Along with the additional symptoms, what are the generalized characteristics of symptoms which are important? The characteristics, the important thing is that these symptoms are generally unilateral, and this shows us that there is a problem at one side on the one cerebral hemisphere. The duration is variable. It can last for a long time. It can be for a very small duration. And the focal motor features, they may supervene later on. And one important thing is there might be a loss of consciousness and tonic-clonic jerking later on. So important thing is the principal symptom is the tingling sensation. The additional symptoms might be a feeling of sense of warmth or rushing feeling or altered sense of movement. And one important thing is that they might start off as a focal sensory seizure and can later on generalize and transform into a tonic-clonic jerking seizure if it involves, if for example, the area of the brain which is involved in initiating this seizure, the problem is expanding. For example, if it is a tumor and it is growing in size, or if it is a bleed which is eventually growing on or increasing in magnitude, then these seizures can transform from from focal seizures to generalized seizures as well. So with this slide, we complete our discussion of the sensory system. We started off by discussing the various terminologies, defining the various terminologies. We reviewed the basic anatomy of the sensory system, and then what are in the latter part of the lecture, we discussed the various signs and symptoms presentation that help us in localizing the problem to the various parts of the sensory system, either be at the level of the receptors or at the level of the spinal cord, the brainstem, or in the sensory cortex. So thank you for watching sqadia.com. I'll see you in another lecture.